I want to thank Julie, and I want to thank everybody else responsible for this conference. This is an amazing opportunity to be a veterinarian in sheltering today and have all of these resources, all of these knowledge resources gathered together. This is a very exciting time. I was a shelter executive director in 1992, 1993. I was 2 years out of veterinary school, and resources like this did not exist. Those of you who've been in sheltering for that amount of time will recognize that things have improved dramatically. And I think the knowledge base that we have, the consulting resources that we have, and the direction of sheltering is very exciting. So for the veterinary students who are here today, things are looking very strong for being able to get the upper hand on some of these problems where we've been struggling in a lot of communities without the proper toolkit. This is my son's note from last fall. Came home on a Thursday night from a shift at my practice, and this was on the countertop, and my wife had left it for me. This was directed anonymously. He didn't know who was making his lunch. I was making his lunch, so it was aimed at me. I was making him sandwiches avoiding peanut butter and jelly because I thought there was a peanut kid in his class. Those of you with children know that there are peanut kids. And if you have a peanut kid in your children's class, you can't have any peanut-related products or bad things happen. So I had been avoiding peanut butter and jelly. This was a disappointment to my son. And so I was corrected with this note. So the message for you is, I've made a sandwich for you. I've put together a lecture, and I think I know what you need to hear. But rather than write me a note, raise your hand if I'm not giving you what you need. If you want peanut butter and jelly, raise your hand. Or find a crayon, leave a note. We'll pick it up later. I'm hoping that by the end of this morning, this presentation at least, you'll have a pretty good appreciation for the benefits, a general overview of how to create standard operating procedures, how to use them and revise them, because they're not static documents. They need revision. They need to be cared for and fed, as it were. We're going to talk a little bit about errors, adverse events, bad outcomes, and some ways to counter that. What I do with students primarily is teach surgery in a very high-volume shelter, 32,000 intake, 22,000 of that cats, about 10,000 dogs, Philadelphia City Animal Control Facility. We're in there 3 days a week with students. We do a lot of surgery. We also do surgery in another facility, so process orientation and having a different group of students every week is a challenge. So standard operating procedures and avoiding bad outcomes through attention to detail is something that we try to live in our program. We're going to introduce the concept of situational awareness, just to give you a sense of who you should be looking for to be a team leader or a surgical coordinator in the OR, or to be managing complex operational tasks, so that there's somebody who's got a sense of the whole process who can be the team leader. And then, believe it or not, we're going to take a lesson from Formula One. So this is a string of benefits. These should be familiar for those of you who use standard operating procedures in your shelters. By the way, how many of you have a book or an online or a computer-based standard operating procedure manual for tasks in your shelter? Got some hands going up. Okay. The alternative to that will be on the next slide, but the benefits to using standard operating procedures are consistency, improved patient care, and process-based quality assurance. So the entire process has built into it methods for checking quality. Improved efficiency. How many of you wish you could do more surgeries, more vaccines in your shelter? If you have standardized processes, it makes you more efficient than having random processes. It facilitates training and cross-training. How many shelters hire people, because they're short-staffed, they hire the first person that can fog a mirror. They assign them to somebody who's already overworked, overburdened, not particularly inclined to train somebody. And they say, train this person to do X, and the training consists of, here's X. and that's their on-the-job training. Turnover is often very high in shelters, so training is critical, particularly when animals' lives depend on how well you do really simple tasks. Cleaning a cage is really simple once you know how to clean a cage. Using the right products, the right materials, how to dilute them, having the right supplies in the right place so you can dilute them properly. These things seem really straightforward, but it's all part of the standard operating procedure, and the introduction to those materials is made much, much easier by having them, and having them handy, having them not in the chief operating officer's desk or sitting up there far away from where the action takes place, but having them near the place where the task is executed. SOPs facilitate leadership development. This is perhaps an odd place to put this, but if you allow your staff to participate in the development of these documents, you give them sort of incremental ability to show you what they know and how they can synthesize and integrate. We do this in our student laboratory. We've got a new program where our students run a weekend surgical opportunities laboratory, primarily cats, but crucial to that laboratory is a surgical team leader. And this is a student who is qualified to do spays, who is prohibited from doing spays for the day. That student has to manage the people, and it's 12 to 14 students that she has to manage for that entire day. So she's qualified to do surgery, but she's not allowed to because she has to stay not scrubbed in. She has to be available to do all of the troubleshooting that a team leader must do in a 60 to 80 cat spay surgical event. So leadership development is perhaps a little off the beaten path, but SOPs and participation in their development can help people become leaders. Facilitates continuous improvement. Adherence or deviation from your standard operating procedures can be a basis for performance evaluation rather than the alternative, which is a somewhat random performance evaluation. And of course, it documents your processes. This is the flip side. Inconsistency, patient neglect, no process for quality, inefficiency, mythic training or on-the-job training, leadership vacuum, stagnation of process, that is, your processes remain static or, in fact, they decline. There's degradation or deviation from process if it's not documented and maintained. So things start to slide if you don't have standard operating procedures. Random performance reviews, very creative problem solving. I admit that sometimes creativity is a gift and it's a good thing, but sometimes creative problem solving is not good for the animals in your shelter. And I love the term tribal knowledge. Tribal knowledge is the unwritten, undocumented way that information is conveyed in many circles. But within your shelter, it's the sense that we do it this way, but I can't point to a document that says we ought to do it this way. But everybody thinks we should, so it's a tribal knowledge basis. How to create them? Well, you can institute them from on high. You can just write them and hand them over, but that can produce implementation challenges for years, potentially. You have to involve your team, and there's actually some literature on the human side that documents this, particularly in surgery. Growing body of evidence that links teamwork in surgery to improved outcomes. High-functioning teams achieve significantly reduced rates of adverse events. So the team produces a better outcome, and a high-functioning team produces the best kind of outcome. That's a disappointment to surgeons, because surgeons are kind of the center of the universe in an OR in their own minds. You know, life in their hands kind of thing. But in fact, it's the team that affects the outcome more than the surgical technique or the surgeon in many cases. This is last year's pumpkin. I was proud of that, but all team members must work with the draft versions of the standard operating procedure. So everybody whose life is touched by that task, everybody who has to implement that task or has to supervise that task has to be part of the development of the standard operating procedure, or there won't be buy-in. They won't do it. They'll resist. They'll complain. Now, they might complain anyway, but if they're not part of the development, you may have very difficult time with adherence to the protocol. We start with a goal, and there are high-level goals, there are process goals, and there might be participant goals. In the case of a teaching protocol, we have goals for our students. And this is an example from a surgical opportunities program that I had mentioned earlier. And so the highest level goal is that for the animals, so that animals are provided high-quality surgical and medical procedures that can be delivered at high volume due to the commitment of a relatively large number of students. For the organization, this is the collaborating shelter on the weekends. That helps fulfill their mission, and then again, a student goal at the bottom. After you establish the goals, you need to sketch out the workflow. And workflow involves a lot of concepts. I've been to a lot of shelters, and I've been surprised when I go into a shelter, particularly a relatively high-volume shelter, and I'll ask to see where intake occurs. And a lot of times, the answer is, well, it can happen here, or it can happen over here, or it happens when ACO brings them in, kind of happens in the garage bay, and there's no dedicated space, and there's no sense of consistent workflow for something that's very important in a shelter. Intake processing is perhaps one of the most important steps for life-saving in sheltering, because that's the time that they get those important vaccinations, and they get at least a cursory assessment of their physical status on the way in. And if the location and the process isn't established, then it's probably not happening with any consistency, and that's an issue. So the workflow, when you're developing a standard operating procedure, the workflow ought to incorporate and include all of those features, provides an overview of the goals and process, and it also introduces the team members that are executing the protocol. Again, from our Surgical Opportunities program, this is an overview of workflow. And so there's a goal within the workflow, and that is that no surgeon is ever waiting for a cat. That is, there's always a cat ready to go as soon as the surgeon has finished the last cat. Animals are never unattended. And then also that the anesthetic time is minimized for these patients. So those are goals that are built into the workflow description. And you can see that there are some other sort of travel-related. Cats progress from station to station, etc. This is part of the orientation materials for this same surgical laboratory. And so the students during their orientation are introduced to these various team positions. The physical exam induction team, prep team, castration station, Spay setup team, Spay recovery team, and then there's a debrief at the end of the surgical session. So at the beginning of the day, there's an orientation or a reorientation because, in fact, all of these students have gone through the orientation online before they come out for the day, but it's reviewed very briefly the morning of. All of the students introduce themselves, even though they typically know each other reasonably well, but they're reoriented and their roles are clarified or identified, and then they go through the rest of the workflow description. And then we get down to the task level descriptions. And tasks include location. Again, for intake processing, that's an important part. If you're asking somebody to prepare dilutions of cleaning product, that happens in a particular location with particular kinds of equipment as well. And I'm adding to this or introducing the idea of checklists. We'll expand on that in just a little bit. Again, this is an example of the task list for exam and induction stations. So physical exam, etc. All of these things have to happen, and they happen in sequence, and they happen in a particular location. This is the surgical facility that was developed to host our students. This particular organization, Philadelphia Animal Welfare Society, used to hold the animal control contract. They were relieved of the contract responsibilities, and they repurposed themselves, became a rescue partner to animal control, developed a surgical and wellness facility. They built it 2 miles from the veterinary school so that our students would have convenient access to it, and they developed it as a very flexible multi-bay surgery with beautiful tall windows. We have lots of natural daylight. Unfortunately, the windows overlook the post office's parking lot, And the post office parking lot patrons are among the worst parkers in the world. So my car was hit about 2 weeks ago. Despite being parked on a small berm, I thought 60 feet away from the nearest car would be pretty safe, but somebody backed into me about 2 weeks ago. I usually get to see somebody get backed into at least twice a day from those windows. This is an example of a exam room cleaning protocol from my practice. My office manager and staff have developed about 50 or 60 standard operating procedures or protocols for various tasks within my practice. I wish I could develop 50 or 60 protocols in my lifetime, but my office manager is very good at this. And this is a detailed description of all the steps. I don't expect you to be able to read it, but this is our current exam room cleaning protocol along with the concentrations and also the renewal or refresh dates for the product. Many of these products have a finite shelf life or life in the bottle. This is a peroxide-based, accelerated hydrogen peroxide-based product, and it has to be refreshed every week in your exam room. So this goes through that in some detail. After tasks in detail, the various roles of the team members. So on-site surgical coordinator or team leader in the case of the surgical program. There is a castration captain. The title for that role was a variety of titles, but they settled on castration captain. Castration captain actually has a sash that says castration captain. Serious about that. They have a sash that they wear, and that's to identify them in a hurry. And that was inspired by Julie's program, Catnip. The surgical coordinator on site for Catnip wears an orange safety vest because in a room full of 100-plus volunteers or 80-plus volunteers with a lot of chaos, it's nice to be able to find that person now when you need them now. So the team captain or surgical coordinator and the castration captain are color-coded, so they're easy to find in the OR. It's not quite as big an operation as Catnip, mind you, and it's a smaller space, but still, when you're in a hurry, you want to be able to find these people. We have Spay certified students, volunteer positions for the day are Spay participants and castration certified participants as well. The team leader identification, documentation. SOPs have to be documented or they aren't real. They have to be documented, and the documents have to be in a place that is accessible when people need to review them, but it also has to be kept by somebody who will maintain them so that not everybody in the organization can modify them. You don't want people altering them willy-nilly. They will need to be revised, but there should be a process and there should be a person or maybe a couple of people charged with revising them. This is an example of a poster that's by one of the workstations. So this goes through, in brief, the various steps for the feral cat prep station, including a depiction of a tipped ear, the positive results of the SNAP kits, and all of this is printed on a nice poster that's right at the workstation. Review standard operating procedures for the process content, that is the steps. Make sure the steps are still the ones that you're doing. And if there's a problem, if people are complaining or if people have suggestions for revising the process, it can be revised. You can change it. You don't have to keep the process exactly the same just because it started that way. Accuracy, clarity, simplicity. Sometimes there are ways to simplify the process and make it easier for people. And also, if the process is necessary. That's a fundamental question. Do we really have to do this, or does it have to happen here? That is, maybe it doesn't have to happen at this particular time. Maybe it can happen at some other point in time. And that's something that your staff can negotiate with you. They may have a suggestion for where a task would be better done at some other place. And if it makes sense or if it's equivalent in the medical care, from the medical care standpoints, that's something that can happen. For example, in this particular laboratory, they were doing vaccinations at the prep station, and the prep station has a challenge keeping up with the surgical paperwork. And so they suggested that the vaccines move to recovery where they've got a little bit more time. There's a little bit more time on the recovery station, a little less paperwork, excitement, and so they moved vaccinations to the recovery side for this laboratory, and that was negotiated. Your team leader, your chief operating officer, your veterinarian should observe for choke points in whatever that task is. In the case of a surgical clinic, what are the choke points? What are the points where everything jams up and you have people standing around waiting for surgery? In a high-volume cat clinic, retrovirus screening is a big choke point. And particularly when people ask for a retrovirus test, but they don't give you the what if it's positive options, which seems to me you're either going to get a positive or a negative. It's predictable. It's going to be positive or negative. And if it's positive, that seems to be something the trapper or the owner or the shelter ought to have given some thought to and given you some direction on the front end of ordering the test. And it happens all the time that you suddenly get this result and it's a complete surprise. It's a positive. And it just shuts everything down while you're trying to chase down a human being to get some direction. That's predictable. That choke point is predictable. A positive test result is inevitable at some point in your day if you're doing a high-volume clinic, and you should have some direction when they're signing the cat in as to what to do with that result. So that choke point is predictable and somewhat solvable, and yet if you don't attend to that on the front end of admissions, you can end up shutting down your surgery or at least jamming up your surgery for 20 or 30 minutes, and you may not even resolve it. You may have the, call the cell phone, rolled over to voicemail, person's out of cell contact and they can't get back to you in time, and then you don't know what to do with the cat. I'm not sure if this made it into your handout, but this is a little bit of a twist. Anesthetic protocol alert. How many of you want a safer anesthetic protocol or are interested in that? Okay. Hoping I have somebody's attention in here. In this particular example, perioperative death rate was 1.5%. Complication rate, complications defined as these: post-op infection, pneumonia, unplanned return to the OR, or death, 11%. New protocol was introduced, dropping the cumulative death rate to 0.8%, 46% reduction. Complication rate dropped to 7%, or a 36% reduction. Is it a new injectable drug cocktail? Fancy new machine that goes ping? A more secure way of ligating the ovarian pedicle in a fat dog spay? I was very excited to see the lecture content for North American Veterinary Conference has Mark Bollinger from Tennessee doing a big fat dog spay lecture. So that's worth a look. No, this new protocol is perhaps the least sexy thing I can show on a PowerPoint slide. Checklists. That's right. Checklists. Introduction of a checklist system in 6 globally distributed human surgical practices decreased perioperative death rate 46%, decreased complication rates 36%. Checklists. Atul Gawande is an author, surgeon, has written a number of books, Complications, the Checklist Manifesto. After this, he was assigned to the World Health Organization's global study of implementation of checklists. So most human hospitals right now are beginning to or are well on their way to implementing a checklist system for surgical practice. And these are the checklists that are recommended by World Health Organization as kind of a template or a blueprint. And they have various hard stops built into them. That is, the patient cannot proceed until the checklist is addressed. And it's a physical checklist. People in the OR have to complete it and have to audibly acknowledge that they have completed the checklist, or the patient does not move. Patient doesn't move out of pre-op. Patient doesn't have an incision started. Patient doesn't leave the OR until these things are addressed. Now, this is the concept. This is something that's rolling out right now. I met with the folks down the street at the hospital of the University of Pennsylvania, the Human Hospital, which has 40 ORs, and they're fairly busy practice, and they're well into this section They don't have the sign-out phase completed yet, so they're not fully integrated into this blueprint. And I'll tell you that our program, our surgical program, is not fully integrated into this. This is something to consider with various tasks that lend themselves to a checklist system. This is developed from the avionics industry, airline industry, where very complicated processes like flying an airplane are incredibly safe, and they're incredibly safe because there's a standardized way of getting started, there's a standardized way of problem solving, and then there's a mechanism for learning from events that happen. So there's a debrief or post-failure analysis that allows them to develop safer checklists going forward. This is some of the data from that study. Again, these were globally distributed hospitals. Each of the hospitals saw improvement, though not every hospital saw improvement in every category. That is, some hospitals experienced reductions in complications, but did not experience improvements in perioperative death rate. But cumulatively and individually, each hospital saw improvement with the implementation of a checklist. There were no other substantial differences in their anesthetic protocols or their caseloads or the case demographics or signalment. So everything else was relatively similar, and this happened in a fairly short study period. So this happened within about a 4-month period of time, so it was fairly compressed in time. Substantial improvement in outcome with the implementation of a checklist system. This is an example of the checklist that our students follow when we're in animal control, as we're getting our patients ready for, and as we're getting our patients processed through a surgical. Again, these are places where we have a hard stop built in. So with dogs, exam patient, confirm the presence of testicles. That seems pretty straightforward, but how many of you have sedated a dog with nothing in the scrotum? You know, that's unfortunate because that dog could have spared, a fairly expensive dose of anesthetic agent potentially, and certainly the dog did not need to have a 4-hour nap in order to have a microchip implanted if he didn't have a microchip already. And again, this is a detailed checklist that our students follow as we're moving through the OR. This is a list of all of the surgical tasks that have to take place from the beginning of the day to the end of the day with a patient. Why is surgery in red? I'm sorry? Somebody says it's the main goal. I can't tell you the number of students who want to get faster in surgery. They want to get more efficient. And they imagine that if they can only get faster, they can do more surgeries per day. But I'll tell you that all of these other things around surgery eat up more time than most. Now, students are somewhat slow, but if you can get standardized processes around all of these other things, and if you can become more efficient at those other things, and if you can keep your surgeon busy all the time, a surgeon who can do a 20-minute dog spay can do an awful lot of surgery if every 20 minutes they're starting another dog. But if there's 10 or 15 minutes between every patient, no matter how fast they are, they're not going to get through a lot of surgery. So I use this slide to emphasize that there's a lot of other stuff that's happening other than the surgical procedure. And all of that other stuff has process around it and needs to be standardized. This is a form, this is actually quite a nice form that our Philadelphia Animal Welfare Society uses as the work order and surgical report for every one of their patients. When we're in their facility, we work off of this sheet, and the sheet has all of the menu options that are available for that particular surgical center. So it has the vaccine list, it has the tests that are available, heartworm or retrovirus, and we can walk through the work pretty easily because it's in a physical or visual format, and we can just check off the boxes and fill in the blanks as we work through the case. That's just a nice, useful form to follow the patient around the OR. By the way, my opening slide was a picture of Operation Catnip from January of 2010. January is pretty cold in Philadelphia, so I thought it's 24 degrees in Philadelphia. I'll come down and visit Julie and Cinda and see Operation Catnip for a Sunday. So we scheduled this, and I came down. 24 degrees in Philadelphia. It was 22 degrees in Gainesville. Thank you. And it was a slow day. They did about 175 cats on a slow day. Julie, normally it's 200, 250 is kind of their, we're feeling good about the day. 250 cats, and you're usually closing your last abdomen at quarter till 1 or 2 o'clock. They're closing their last abdomen. 250 cats, roughly half female. So that's organization. That's some standardized operating procedures. This is an example of an exam station list. Just a slide or two about surgical standards in veterinary medicine. This is a screenshot from the American Animal Hospital Association, organization very near and dear to me. Accredited practices adhere to roughly 900 standards, and there are some specific standards for various parts of practice. There's a lot of standards around surgery, medical records, and so forth. This is just an example of some of the standards around surgical practice. When you're developing standard operating procedures, you have to keep in mind that there is an emerging sense of standard of care. There are spay and high-volume spay and neuter guidelines that have been published for a few years. So there are standards, there are resources that you can go to see if what you're doing is in conformity to those standards. It used to be that there were local or prevailing standards of care in veterinary medicine. So if you were far from the big city and you were in a somewhat rural area, it used to be considered you were held to a different standard of care by veterinary boards of veterinary medical examiners because you didn't have access to or ability to have the latest and greatest knowledge or gadgets. I will tell you from talking to people who sit on boards, veterinarians and representatives of the public, that sense of local standard is changing, and it's now one standard because knowledge is now easily available. Conferences like this, other veterinary medical conferences, can easily distribute information about the latest and greatest ways to do things. The internet has made veterinarians have access to information that used to take a much longer time to distribute. So the sense today at boards of veterinary medical examiners is that you should know this stuff, and you should know about pain management, and you should know about appropriate surgical protocols because it's easily available now. So there is this sense that there are emerging standards. Those standards are going up, not down. It is no longer the shelter held to a different standard than a practice. You do need to keep that in mind as you're developing protocols because your protocols may come under some scrutiny, either from a volunteer who doesn't like what you're doing, who may take a photocopy or take a screenshot of your protocols and share that with other people. So as you're developing, not that that's the only thing to consider when you're creating protocols, but just keep that in mind. Your protocols need to be sound medically. We're hoping also that people are paying attention to the ASV's guidelines for shelters. Pay attention to what your state boards, those of you who are in contact with people who've had experience with the state boards, or if you get a publication from your state board, if you're a licensed veterinarian within your state, they probably send out some information to you on a quarterly basis or yearly basis.